Hello students, welcome back to our channel. In today's topic, we are going to discuss about poliomyelitis, which is otherwise called as polio definition. So in this video, we are going to discuss only about the orthopedic part and its PT management, that is physiotherapy management. So for the detailed video, please do leave a comment and I'll make the video for you. Poliomyelitis is a viral infection caused by the polio virus which affects the anterior horn cells of the spinal cord, leading to acute flaccid paralysis and muscle wasting. It primarily affects the children under 5 years of age. Etiology: causative agent is poliovirus type 1 to 3 enterovirus family. Mode of transmission: fecal-oral route, contaminated water and food, occasionally droplet. Incubation period 7 to 14 days. Clinical features: minor illness, abortive polio, mild flu-like symptoms. Non-paralytic polio, headache, neck stiffness, muscle tenderness will be seen. Paralytic polio, flaccid, asymmetrical motor paralysis without sensory loss. Features and description: if it's fever, initial symptom, muscle weakness, asymmetrical blood, but it's flaccid. Reflex loss, hypo or areflexia will be seen. Muscle wasting develops over time. No sensory loss, sensory pathway remains intact. Bulbar involvement may affect the swallowing or breathing. Stages of polio: stage 1, that is acute, subacute and chronic. In acute stage, 1 to 2 weeks, viral invasion, fever, muscle pain, flaccid paralysis. In subacute stage, that is 3 to 6 weeks, recovery begins, partial return of strength. In chronic phase, that is more than 6 weeks, residual paralysis, contractures and deformities will be seen. So what are the medical management? How will be treating with the medical side? Supportive care will be given, that is bed rest, hydration and pain relief. For the respiratory support, if bulbar polio affected, the breathing will be affected more. Antipyretics for fever control. Physical therapy being during subacute phase. After subacute, will be definitely going with the physiotherapy management. Surgery for the deformity correction or the tendon transfer in chronic stages. Vaccination prevention: oral polio vaccine OPV or inactivated polio vaccine IPV. Physiotherapy assessment: for acute stage, the assessment tool will be pain assessment, VAS, muscle tone, temperature, range of motion using goniometry, respiratory status. In subacute, muscle strength, MMT, joint mobility, posture control will be seen. For the chronic stage, functional assessment, that is aerial, gait, deformity analysis and orthotic needs. Physiotherapy aim: to maintain the joint range, to prevent the contractures, to facilitate the muscle recovery, enhance functional independence, train in mobility and gait, promote community and home-based rehabilitation. Treatment technique: so the treatment technique will be based upon from the scratch. It's from positioning and splinting, prevent contractions, passive range of motion exercises to maintain the joint flexibility, isometric exercises for the weak muscle grade 1 to 2, progressive strengthening from gravity eliminated to gravity against, gait training with crutches, KAFO walker, balance and coordination, functional retraining, hydrotherapy to reduce the gravity and improve mobility, functional training, sit to stand, stair climbing and transfers. Common deformities when we talk about the polio, we can see equinus foot AFO, stretching, gastrocnemius, genu recurvatum KFO to stabilize the knee, scoliosis will be seen. So the postural correction and spinal orthosis can be given. Hip and knee contractions, positioning, strengthening, claw, hand and foot, functional splints. Tendon transfer operations in polio: posterior tibialis to dorsum of the foot, for foot drop, triceps to biceps transfer, elbow flexion restoration, gluteus maximus to ilius vas, hip flexion, hamstrings to quadriceps, knee extension, sternocleidomastoid to trapezius, that is shoulder elevation. Post-op PT, immobilization as per surgeon's advice, gradual range of motion, strengthening of the transferred muscle, functional re-education. Common orthoses used: AFO, there is ankle, foot orthosis, prevent equinus deformity. KAFO for knee, ankle, foot orthosis to stabilize the flail knee. HKAFO for hip, knee, ankle, foot orthosis for extensive lower limb paralysis. Spinal braces, TLSO for scoliosis. KAFO measurement and checkout. Measurement step: measure the leg length from ischial tuberosity to heal. Thigh, knee, calf, and ankle circumferences. Check joint level alignment, knee and ankle. Show size for the foot plate or the foot section. Record weight bearing status and foot alignment. Check out, ensure proper fit and alignment. No pressure areas or the skin breakdown. Ensure stability during walking. Train in donning and doffing the orthosis. Home program and orthosis care. So the exercise will be range of motion and strengthening exercise, daily basis, orthosis care, regularly clean, check for wear and tear. Skincare, inspect for wetness, pressure ulcers, and etc. Mobility training, practice gait with orthosis crutches. Education, caregiver training for transfers, positioning. Function to promote independence in ADL, follow up regular PT visits and orthotic review. So let's summarize what we have discussed in the entire 6 minutes. Definition: it's a viral anterior horn cell damage leads to paralysis. Transmission: it's feco-oral route. Stages: acute, subacute, chronic. PT goal: to maintain the range of motion and to restore the function, to prevent deformity. Common deformities seen in this poliomyelitis is equinus, genu recurvatum, and scoliosis. When we talk about the tendon transfer, we'll go for foot drop, elbow flexion, hip, knee function. Orthosis, KFO, AFO, and spinal brushes. KAFO measurement, accurate anatomical fitting, and skin check. Home program, HEP, exercise, orthosis care, and family education. If you want me to make a detailed video of each and every topic, please do leave a comment. Happy learning, happy journey.